Dear viewers, welcome you all to our show, Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, before starting our program, I would like to show my deep respect to the father of nation of Bangladesh, Bangabandhu Sheikh Mujibur Rahman, and those martyrs who sacrificed their lives and everything to give us an independent Bangladesh. And definitely, I would like to give my salute to the people of India and the people of Russia who stand behind us during that crisis moment of Bangladesh. Dear viewers, this is the month of December. This is the month of victory and this is the month of proud to all Bangladeshi. And today, our topic is the trifocal osteosynthesis for management of large bone defect. And our honorable speaker is Dr. Amar Sani from Gujarat, India. I would like to request Dr. Amar Sani, sir, to join with us. So welcome to our show.
Thank you, Dr. Tanvir, and thank you, Dr. Bari sir and Navik sir, for providing an opportunity to present at this forum. Thank you, sir. Good afternoon, sir.
Thank you very much. Good afternoon, sir. And dear viewers, we have learned academic expert with us. We have Professor Mofakharul Bari, sir, the legendary reserve surgeon from Bangladesh. I would like to request Professor Mofakharul Bari, sir, to join with us.
Yeah, thank you, Tanvir, for introducing me. And really, you mentioned this is the month of December, and we're very much grateful to India and Russia for our, 71 war fighting. And 16 December is our victory day. Thank you very much again.
Welcome, sir. Welcome to our show. And I would like to request another academic expert, the highly academician Professor Novikov, sir, from Kurgan, Russia. Sir, welcome.
Good afternoon, dear colleagues, and I think today our topic will very interesting for all of us.
Thank you very much, sir, for joining with us. Dear viewers, we have another learned academic expert from Patna, India, Dr. Shamsul Huda, sir, and he will join in the coming part of our program. Now, I would like to request. I think he has joined with us. I would like to request Dr. Shamsul Huda, sir, to join with us. Sir, welcome to our show, Orthopedic Solution Academy.
Thank you, Dr. Tanvir.
Thank you very much, sir. Dear viewers, now I would like to request our honorable speaker, Dr. Amar Sani, sir, to present his excellent topic, that is the trifocal osteosynthesis for management of large bone defect. Dr. Amar Sani, sir, would you please share your screen with us?
Yes, sir. Thank you, sir. I'm sharing my screen. Dr. Tanvir, sir, my screen is visible now.
Yes, sir. It is absolutely visible, and we
I'm
can
audible.
see your slide clearly, and we can hear you loudly. So it is perfect.
Thank you, sir. Today's my topic is trifocal osteosynthesis for management of large bone defect. Usually, a defect which is more than 8 centimeters is result of high velocity trauma. Mostly, it is a grade 3 injury sequence, and apart from bony gap, there is significant soft tissue loss and soft tissue injury. At times, we get such bone defect post benign tumor excision also. Such bone defects are basically a therapeutic challenge for surgeon and patient. It requires stage treatment, whatever may be the treatment modality chosen, and it requires prolonged duration of treatment. And at times, complex reconstruction requires multimodality approach in the form of orthoplasty, orthopedic surgeon, and plastic surgeon both together. What are different options to treat such defect? Vascular or non-vascular fibula, muscular technique, segment transport, and hybrid fixation. Vascular fibula is an excellent option when the defect is very large and there is not enough healthy bone for single or dual corticotomy, or at times the soft tissue bed is not as example post irradiation or peripheral vascular disease. Limitation of such treatment is it requires a tertiary care center to execute such thing, as it requires microsurgical anastomosis and expertise of vascular or plastic surgeon, and there are some donor side morbidity too. Non-muscular fibula, it takes too long to unite, too long to hypertrophy, and still it requires protection in cast or brace. Chances of refracture are too high, and unprotected weight bearing takes very long. Cumulative morbidity is too high, and I would not suggest any of my younger colleagues to choose non-vascular fibula option for managing such large defect. Muscular technique, the biggest advantage is healing of bone defect as not dependent on its size of defect. That means a 5 centimeter defect and 15 centimeter defect both can heal in same time frame. But there are some disadvantages also, some limitations also. Soft tissue coverage is must for muscular technique. Once recurrence of infections, there are chances of secondary amputation. At times, bone source is limited as posterior crest provides around 40 cc and anterior crest provides around 15 cc of graft. In that event, graft can be expanded with RIA, allograft, or bone graft substitute. It requires prolonged IV antibiotic for period of 6 to 8 weeks, prolonged hospitalization, and knee weight bearing for longer period. Average time to full weight bearing is around 7.5 months. Hybrid fixation in which initially transport is done over nail, and once transport is over, a frame is removed and fragment is locked. Another option is segment transport with LRS. The limitation of LRS, it is least modular thing. Axial stiffness is high and shear stiffness is low. And as compared to 1990 spanning, uniplanar frame pin configuration has less stability. And as these pins are inserted from lateral to medial aspect, though it may be from safe zone, but excursion of tibialis anterior, EHL and EDL is significantly affected while uh, fragment is transported. There is no provision for preventing equinus in such frame, and most of patients are in nil weight bearing or toe touch in majority of treatment period. And in femur, when LRS is used for segment transport, if defect is more than 6 centimeter, chances of hip varus are high. Segment transport with Elizaro for large bone defect, it is the indication. It provides excellent outcome, both functional and radiological, and it obviates need for plastic surgery in flap cover. But it has some limitation also. There are some regenerate issues, means hypertrophic regenerate deviation. At times stability is a issue, at times biology is an issue. Docking side non-union malunion is often seen, and if foot frame is not applied, equina occurs usually with such large transport, and duration of treatment is long as healing index on an average is around 30 to 45 days per centimeter, and in some case it may even extend up to 60 days per centimeter. There's long learning curve. So means why one should opt for trifocal osteosynthesis, means what is the need for that? Because whenever the Elizara fixator is applied, it is usually applied as the first and final fixator, and when frame is kept for 15 months or more than that period, generally wire deforms elastically, and over a period of time it deforms plastically. The pintract issue, loss of pages, and patient requires frequent follow-up visit, and financial burden, morbidity, disturbed psychology often leads to premature frame removal, refracture, persistent of non-union, even at times amputation, and lost in follow-up. And last year in 2020 January, Dr. Dor Pele had came to India, and in conference he had said this thing that Elizabeth principle will remain forever, but its apparatus may not. Means most of things now these days they are doing with internal fixation or fixator assisted things, but it will not stand true in developing country like India and Bangladesh. And in management of open fracture management, it still holds a good place apparatus. And but we should take every effort to reduce the time in frame and as and when possible without compromising the outcome. One should understand the terminology of bifocal osteosynthesis versus monofocal bifocal lengthening. When one is doing lengthening, if it is done through single corticotomy, one can term it as a monofocal lengthening, and if it is through two corticotomy, one can say it as a bifocal lengthening. But in event of transport, bifocal transport, a term coined by Dr. Ketani, where a process of bone healing occurs at two different sites. A corticotomy site regenerate occurs and a docking site union occurs. So in bifocal, one can have a simultaneous dissection at corticotomy site and compression at fracture site. An alternate way is to accelerate compression at docking site and gradual dissection at corticotomy site. This stands true for smaller defect less than 6 centimeter where you can do accelerated compression or acute docking. But for larger defect, it is not a good option. And in such acute compression, lever arm of muscles become less. So there is a type of pseudo paralysis, and one need to give compensation till limb length discrepancy is addressed. Trifocal osteosynthesis is termed where a process of bone formation occurs at three places, two corticotomy and a docking site. A converging trifocal in which transported fragments are converging towards each other to dock, and tandem trifocal in transported fragments run in tandem to reach the other end. One can have all wire frame or one can have a frame with wire and half pin hybrid frame depending on surgeon preference. But when one is doing tandem trifocal osteosynthesis, proximal ring bears the brunt of dissection, and all wire frame have possibility of procurvatum and valgus if single ring is used. Regarding all wire frame, spanning 1990 spanning is difficult in transported segment, and one cannot give much more stability on single ring with two or three wire. At times, one has to insert drop wire. And regarding all wire frame, which gives good axial micro motion, that concept comes when fragments are docked. Before that, once fragments are transported, one need to give good stability, which is given with hybrid frame. And here in transported fragment with medial face wire and perpendicular half pin give 90-90 spanning prevents toggle of fragment, and regional deviation is seen less often. And once docking is done, one can dynamize the frame and gradually remove half pin. One can see a case where converging trifocal osteosynthesis is planned with four rings and a foot ring. This is what my converging trifocal frame, prefabricated frame will look like. Corticotomy will be done between first and second ring and third and fourth ring, and second and third ring will be gradually compressed. These are post-corticotomy X-ray and defect of X-ray, clinical picture of frame post-fixation. Another case where we have done a tandem trifocal osteosynthesis, large defect, middle fragment removed, a prefabricated frame where two corticotomy done between first and second ring and second and third ring. Last ring is kept as a carbon ring to have a good radiological assessment of ankle joint and docking site. This post-fixation X-ray and docking site X-ray, gap site X-ray, clinical picture of frame where in proximal fragment three wire and two half pin are there, and in transported fragment a medial face wire and perpendicular half pin is there. One can choose a single rod versus individual rod between each ring depending on surgeon's preference. But when one is doing tandem trifocal single rod, one is having very difficulty in comprehending how to transport the fragment. I prefer to use individual rod to connect each ring, and routing segment I prefer a wire and half pin instead of two wire because two wires give less spanning as compared to a wire and a half pin. This is a frame applied by someone else, but it is not a properly applied frame. So one should have a proper, all four rods should be of proper length. It should be at zero level at proximal side, and it should be at equidistant place. As suggested in books, one should have a two ring in proximal fragment and two ring in distal fragment, and floating segment will have a ring. But it is not possible to have in each and every individual to apply two ring, as our patients are not that in big in height as compared to Western patient. So at times we have to treat such patient with single ring on proximal fragment, and corticotomy to be done between first and second and third ring. Here, I have applied foot ring to to treat equinus, and even if there is no equinus, one need to apply a foot ring to prevent equinus and have an adequate lever arm of distal fragment. Regarding how to prevent angulation, whenever one is inserting a frame, a proximal tibial wire which should be parallel to knee joint and distal tibial wire which should be parallel to ankle joint, if these two wires are perfectly parallel to knee and ankle joint and all four rods are equidistant, then one should not have any angulation. Corticotomy Metaphyseal corticotomy I always do with freehand technique with 5 mm, osteotomy with 5 mm incision. When diaphyseal osteotomy I used to do with Gigliso or at times multiple drill hole technique. Here in distal fragment, distal corticotomy is done with freehand technique, while diaphyseal corticotomy is done with Gigliso. At times, one is having adequate bone but not unhealthy bone to do corticotomy. As you can see in such case where whole segment is affected with infected. So in that case, I have done only distal corticotomy, not another corticotomy in tibia, but chose to do a corticotomy in distal femur instead of two corticotomy in tibia. Regarding the rate and rhythm, usually after 1 week of latency, I start distracting at 0.75 mm to 1 mm per day, initially 3 times, and after 1 week, 4 times in a day. And any patient who is having a segment transport is likely to have a dull aching pain due to transport because not only bone but skin, soft tissues are stretched. If one is more pain, one can reduce rate or rhythm of dissection. If more, one can stop diaphyseal. If still patient is having pain, one can stop diaphyseal and metaphyseal both corticotomy dissection. At times, compress it and re-distract it. How to monitor rate and rhythm? I apply a paper tape on each four rod and I give a direction in which direction patient has to do dissection, and I write a date on that so that when patient comes in follow up, we will have fair idea whether he has done a proper dissection or not. And tape is applied on each rod so that if patient is not doing even dissection, one can immediately notice clinically only. And these paper tapes are changed at follow up in every follow up. Here, this patient has done uneven distraction, which one can easily appreciate even in clinically before taking X-ray. Regarding follow-up visit, I usually discharge patient 1 week after latency. Once patient understands the process of distraction and compression, I usually discharge patient. I ask them to come for follow-up at 2 week interval. Once docking is done at 2 week post docking, I ensure that this limb length discrepancy is addressed, and after that, patient can come for extended period follow-up, say 6 to 8 weeks or even 10 weeks. Docking is most important part of segment transport and Elizar treatment, and many times I have seen results are ruined because adequate care is not taken at the time of docking. This is a case which is treated elsewhere where 12 centimeter segment is transported, good regenerate, but docking side non-in, and ultimately patient land up in amputation. Another case, 8 centimeter segment transported but persistent non-innate docking site, persistent shortening and equinus. Another case, non-in at docking site, good regeneration. So one should give adequate focus on docking, otherwise whole effort will go in vain. Here there is good regenerate, but docking site is in varus and procuratum. Here regenerate is good, but there is gross angulation, and such results are not acceptable if one is interested in treating such patient with segment transport. Regarding refreshing of bone ends, I prefer to refreshen bone ends at the time of initial debridement because at the time of docking we'll have constrained space. It will be very difficult to refreshen bone end in that constrained space with two rings very near to each other. And skin invagination will occur in each and every patient with such large transport. One has to incise skin, remove fibrous and fibrocartilage tissue over the bone ends, open the canal, and skin will heal by secondary intention beautifully, as one can see in this case. Regarding docking side malalignment, one can address it preoperatively before posting patient to docking with help of biplanar hinges and washer. And adequate surface area is essential to have increased stability and limit the less chances of refracture post frame removal. Fibular osteotomy I do at the time of docking so that one can compress it acutely. Otherwise, it will be difficult to compress it acutely. And post docking, I advise patient to do dissection so that limb length discrepancy is addressed. In stage where fragment is transferred from distal to proximal site, I avoid fibular osteotomy and I allow wound to heal by secondary intention post removing skin invagination and fibrous tissue. And these usually occurs in 10-15 days. So by this time, generally wound issues do not occur. Bone graft. I seldom apply bone graft at docking site because with increased vascularity and stable frame, this requires rarely a bone graft. But in elderly patient who has undergone multiple surgeries, one can put bone graft at the time of docking with idea of not to take any chance. Post-docking dissection is essential to address limb length discrepancy, otherwise patient will have residual shortening of around 2 2.53 centimeter. And once post-docking dissection is there, patient will have limb length discrepancy addressed. Another thing which I've seen in Kurgan is the acutely compressed around 1 centimeter dissection that helps in early healing of early consolidation of regenerate. Foot ring removal I usually do 6 weeks post docking. Uh, Clinical testing in each of my case, I always remove rods at fracture site and corticotomy site and ask patient to walk if he is pain free. If there is no abnormal movement, clinically there is no abnormal movement at fracture site, and he is able to walk in corridor. That means there is good union, and one can now start dynamizing the frame. So this is the sequence of frame removal which I follow. Clinical testing, dynamism. Ask patient to walk as much as possible, unaided walking, even allow him to do cycling, and radiological assessment of regenerate and docking during follow-up visit. And I remove frame, and usually cast or brace application doesn't require, and rarely hybrid fixation is required. Regarding treating such defect as a visiting surgeon, I usually do not prefer as a myself as a traveling ELISA surgeon. In very few incidents, I go to my colleagues where I have a good rapport with them, and I never go as a host surgeon because in such situation results will not be optimum, because if you do not counsel patient properly, I don't think that we can give optimal result. And in even when I have treated patient elsewhere, I usually insist for follow-up at my place. In this case, this patient was treated by laser surgeon, but index surgeon could not do adequate counseling, and patient opted for amputation even before corticotomy. Uh, Implication of trifocal osteosynthesis. This patient had came from Cameroon, Africa, and I did double corticotomy, and her stay was around 4 months only. If I would have done single corticotomy, she would have to stay in here for around 6 months. So it significantly reduces stay in hospital for patients who are coming from such a far distance. Another case, lady from Kenya, which I was able to discharge in 4 months. If I would have done single corticotomy, I would have keep her for a period of 6 months in my hospital. I'll share a few of my cases where I've done trifocal osteosynthesis, and this case, which is treated by my colleague, a large gap, initially external fixator, later on Elizarov, and he has done single corticotomy, and it he healed beautifully in 16 centimeter gap, healed beautifully in 18 months. I have nothing against this, but it takes little longer in frame in such large gap if one is doing a single corticotomy. Uh, this is my case where there is open grade 3B fracture with healed wound. Initially, I thought of preserving middle segment, but on opening it had hardly any periosteal attachment. It came in my hand, so I had to remove it, and I planned for tandem trifocal osteosynthetsis. The resultant gap was very large, 20 centimeter. Foot ring was applied to prevent equinus. Here, the corticotomy was done between first and second ring and second and third ring, and at 11 half one frame was removed and without any limb discrepancy with good functional outcome, and healing index was external fixator index was 17.2 days per centimeter, and he has excellent functional outcome. Another case, lady from Cameroon, Africa, bilateral infected non-Indian TB. Right side was more gap. Uh, Here on right side, I opted for converging trifocal osteosynthesis, 18 centimeter gap, equinus correction assembly applied, proximal and distal tibial corticotomy done, docking done at 4 months, and she left India at 4 months and removed frame at Africa only. She was in frame for around 2 years because she had not came in follow-up due to this COVID pandemic, and she removed frame there only. But she had good functional outcome, and she was able to walk unaided post frame removal, and her both leg healed beautifully. 61 year age, 3 year post injury, 11 surgeries, multiple bone grafting. So elderly patient, multiple surgery, low morale, rehab is difficult in such case. He was bone grafted for 3 times, disease osteoporosis because of not walking, and financial constraint and psychological disturbance are there. In such case, if we extend frame for say very long period, patient may not cooperate. So I planned for double corticotomy, tendon trifocal osteosis, and at 16 months I was in position to remove the frame, and it healed nicely, and patient was in position to walk nicely. Another case patient presented to me 6 months post injury. This was the situation at the time of presentation. All half pins were loose. Patient was having severe pain, so he used this cloth to hold the pin in position. He was even treated with cross leg flap initially, which was rejected. Large gap, 16 centimeter gap, tendon trifocal, docking at 3.5 months, and frame removal at 11 months. External fixator index is 20 days per centimeter. 6 months post frame removal, there is slight residual varus at distal end and increased slope of proximal tibia, but good functional outcome. Another case, no apparent bone loss. Initially, grade 3B injury treated elsewhere with external fixator. Magnitude of soft tissue injury was underestimated. Initially closed primarily, then a whole flap was rejected. When he presented me, a large part of bone was exposed in avascular. I did converging trifocal osteosynthesis, and at 10, this is pre-docking situation. And once I did docking, two rings were very near to each other. In such case, it is better to reposition a second and third ring so that radiological assessment would be easier of docking side. Post-docking dissection done and clinical testing done at 10 months, and this patient awaits frame removal now. Elderly patient, 70 year age, vehicle accident, low socioeconomic class, treated with external fixator, exposed avascular bone. It presented to me at 12 weeks. Uh, whole avascular bone removed, 15 centimeter gap, did tendon trifocal osteosynthesis, carbon ring at distal part for better radiological assessment, proximal freehand technique corticotomy and diaphyseal giglisocorticotomy, transport, and at 80 days I was able to dock him, and at 10.5 month frame removal was done. Good functional outcome and healed nicely. Protected in breast for few months. uh, Last few cases only, giant cell tumor with pathological fracture, detailed counseling done for megaphosis versus resection orthodosis. Each patient took 6 weeks to decide whether to go for megaphosis or resection orthodosis. Whole proximal tibia was resected and blocked, and across knee frame was applied. Distal femur and distal corticotomy done. Docking done at 2.5 months. As one can see that post docking, there is no pin check issues. And at 9 months, I was in position to remove the frame, and external fixator index was 22.5 days per centimeter. And as one can see that it has knee has orthodox beautifully, and overall alignment is good. Another case, osteosarcoma treated with megaprocesses, which broken processes, explained all treatment modality, amputation, fusion, revision, and patient opted for fusion due to cost constraint. Removed broken processes, 16 centimeter gap, distal femur and distal tibia corticotomy, docking done, 10-month post procedure, and frame removal at 14 months, external fixator index 26 day per centimeter. At 3 year post frame removal, whole regenerate, consolidate nicely, and knee fuse nicely, and patient walks unaidedly. So these are the usual procedure which we do post in such cases: skin graft, corticotomy, docking, fibulostomy. Bone grafted docking is seldom required. Bone grafted regenerate site is rarely required. Frame modification in under anesthesia is rarely required, but I usually address any instability when I do docking. TL landing in some cases if one has not used foot frame, because I use foot frame in all cases of large transport. TL landing was not done in any of my cases. I have not used antibiotic bits in any of my cases, and repeat bone graft at docking site was not done in any of my case. So literature shows these many problems, obstacles, and complications, but many of these are not seen in our series. So, what is the take-home message? Is this tandem trifocal osteosynthesis significantly reduces external fixator index. It reduces not only external fixator index, it reduces stay in hospital. Number of additional procedures are less as compared to what is shown in literature, and true complication is less. And follow-up visit, travel, and treatment cost is significantly reduced, and most of patients return to pre-injury occupation when one has applied frame properly with adequate stability. So, degree of bone loss is not the only determining factor for amputation. Patient factor regarding age, comorbidity, smoking, alcohol, peripheral vascular disease do dictate whether patient should go for salvage or amputation. A motivated patient and detailed counseling gives excellent outcome. Thank you. Thank you, sir.
Thank you very much, sir, for your excellent presentation. Uh,
Thank you, sir.
that was a magnificent presentation. Now, I would like to request Professor Mofakrul Bari, sir, to share his knowledge regarding the trifocal osteosynthesis. Professor Mofakrul Bari, sir, please.
Thank you. Can you hear me?
Yes, sir.
Yes, sir.
We can hear
Yes.
clearly, sir.
Thank you. Very good. Very excellent presentation.
Thank you, sir.
The I must congratulate Omar Sani for giving a elaborate idea regarding the big bone defects. And really, you have mentioned all the pros and cons of your paper. And especially, in our third world country, where we have a densely populated people and poor people, neglected treatment are going on all the time. And to
Yes, sir.
salvage all these kinds of problems, difficulties, I think Elizarov is the good option, best option, I should say. And you rightly mentioned more than 8 centimeter. There are lots of treatment modalities, but what I've seen in my life and the cases that you have shown, all kinds of these kinds of varieties of treatment, varieties of cases that I'm also doing with bifocal, trifocal. Trifocal really it is a very good, and the biological parameters, the shown by the academician Gabriel Abramovich Elizarov, we are still following all these kinds of things. And in literature you can see the regarding the complications, obstacles, and other problems. You can they have written a lot of things, but in real life you cannot see all these things. And I have a publication. I know whenever you send one of these trifocal in the Facebook, then I congratulate you at that time. And I told you you can
Thank you,
see my
sir.
publication also trifocal that I have done in
Thank you, sir.
American Medical Journal. You remember that one. So
Yes, sir.
thank you very much for giving
Thank you,
your
sir.
knowledge to all the budding orthopedic surgeons. It is really a learning case, and only the salvage procedure that you have shown. And thank you very much for your nice presentation and deliberation and showing us the difficult cases. Okay, thank you again.
Thank you, sir. Thank you, sir.
Thank, thank you very much, sir, for sharing your knowledge. Now, I would like to request Professor Novikov, sir, to say something regarding the presentation, sir, please.
Dear Professor Sani, I want to congratulate too
Thank you, sir.
you and your colleagues with excellent result. And just now we can see few cases you show with monolateral monofocal device, and doctor cannot get real result, and only when we start support patient with principle of Elizarov. I won't repeat it again, doesn't matter which kind of frame we will use, principle of Elizarov. And I am
Yes, sir.
very happy because just now in the India, in Bangladesh, we have excellent surgeon who can real support any patient, not only poor patient, including Africa, including Asia. And just now, I think if we will comparison our results with another part of our world, your result is good, it's perfect. Congratulations.
Thank you, sir. Thank you, sir, for kind words, sir.
Thank you very much, sir. Thank you. Sir, I have one question to you, sir.
Yes,
You
please.
told that you will do destruction in the part of docking, but when you will start the destruction?
No, no. What I said is once you do docking, means at the time of docking, you will compress the bone ends around 2 to 3 centimeter acutely. So once you have done docking, then also you should start continue restricting at corticotomy site so that patient will not have a limb length discrepancy. At times, what we see is once docking is over, doctor do not advise them to continue distracting at corticotomy site. So patient will have a residual shortening of 1.52 centimeter, and which is very commonly seen in patients who are treated with LRS, because they do not advise patient to continue distraction till limb length discrepancy is addressed.
Okay, thank you,
Yeah.
sir. Thank you very much, sir. Now, I'd like to
Thank
request
you.
Dr. Shamsul Huda, sir, to share his knowledge and if he has any question to Dr. Amar Sani, sir. Dr. Shamsul Huda, sir, please.
Thank you, Dr. Tanvir. It was a real wonderful talk by Dr. Amasoni. It is a real
Thank you, sir.
learning every day. He has seen a variety of cases from all the aspects, tumor, distraction, everything. So it's a very good case. We learned a lot. Thank you. Thanks a lot.
Thank you, sir.
Uh, Thank you very much, sir. I would like to thank our honorable speaker, Dr. Amar Sani, sir, and I would like to thank our academic expert, Professor Mofakarul Bari, sir, Professor Novikov, sir, and Dr. Shamsul Huda, sir. Dear viewers, we want to end up our program today and hope we'll see you in the coming Friday with another topic. Before that, I would like to thank Raj TV for helping us to arrange this type of academic program, and definitely Leonardo Pharmaceuticals Bangladesh Limited for sponsoring our program. I'm Dr. Mohammad Tanvir Ashraf saying bye-bye to you today. Hope we'll see you in the coming Friday with another magical Elizarov topic. Bye-bye.
Thank you. Thank you, sir.
Thank you. Very good.
You
Thank you,
are
everyone, sir.
watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.